We're looking very forward to our speaker today, Dr. David Schall, who is a MD neurotologist, aerospace neurotologist with the FAA certified physician. He's going to give us a talk on otologic and neurotologic conditions. And it's a very relevant talk for all of us to keep up. And even though there's less flying because of COVID, there's a lot of people that are still flying.
Thanks, Bill. I appreciate it. So I'll share a little bit about my background. I did a residency in aerospace medicine and got board certified in that as part of my aerospace, did a master's in public health at Hopkins, did my ENT at Nebraska, and then fellowship with Mike Glasscock back in the last century. I think I was this 36th fellow, and Lloyd Miner and Sean McMenemy were part of my litter mates. I'm a private pilot. So I spent 37 years in the Air Force, flown in 42 different kinds of aircraft, and have over 1,600 hours. Also have worked as a regional flight surgeon for the FAA, and have been with the FAA for over 10 years, and I've reviewed over 20,000 airman cases. So not a lot I don't get to see, and since I'm the inside guy, I get all the interesting ENT cases, and I'll share a little bit about that. But before we get started, there's my Steve Canyon pictures. We'll talk a little bit about aerospace physiology, a little bit about the types of medical certificates that pilots may request, who does these exams, the FAA hearing standards, and a little bit about safety sensitive duty and medications, and then we'll get into some actual cases. So why should you care? You'll be seeing airmen and they'll be asking you about their condition and flying. And as a FAA reviewer, unfortunately, I see some pretty silly and not helpful recommendations. And here's an example of what I've got. Steve's okay to fly. Well, thank you, but that doesn't really answer the mail. So we'll give you an idea of kind of what we're looking for. So a little bit about the physiology. Obviously, it's not like driving a car on terra firma. There are a lot of different things in the environment that can affect various medical conditions. So pressure changes obviously being most significant. Cockpits tend to have very low humidity. There's thermal stress, vibration stress, obviously hazardous noise, and then there's acceleration. And so, and how that plays with our vestibular system is a cause of many spatial disorientation accidents. And then finally, there's even radiation. And many of our international flights, depending on if there's a solar flare or an eruption, can be exposed to significant radiation, and also from radars, aircraft radars putting out microwaves, etc. If you're close enough to the aircraft, can cook you, so to speak. John Stapp did a lot of work on back in the 50s on what the human body could tolerate in the ways of acceleration, and he earned a few retinal hemorrhages out of some of these sled rides. And actually donated his body to science when he passed to look at the long-term effects of acceleration. And as you go higher, obviously the pressure gets less, and so the partial pressure of oxygen and the pressures on our sinuses and our ears can be affected. We saw the effect of this in the scuba talk last week, talking about ear blocks and inner ear barotrauma, etc. So here's the typical oxy-hemoglobin dissociation curves, and basically why you need to be on oxygen as you go above 10,000 feet. Here in Colorado Springs, I live at 7,000 feet. And so fortunately, I don't need to be on oxygen, but it allows me to very quickly adapt to the mountains when I go skiing and when I fly as a pilot in Civil Air Patrol. Vibration comes in various frequencies and from different sources, whether it's engines, rotor blades, et cetera. And now we have space flight. And so vibration associated with entry and re-entry can be significant. We talked a little bit about the spatial disorientation, but there are a host of illusions, somatogravic, somatogyral, et cetera, that are associated with our vestibular system trying to adapt to an abnormal environment. And we do a lot of teaching on for pilots to begin to understand some of these illusions. For example, a carrier pilot, when he launches off the carrier and the catapult, has a tremendous sensation that the aircraft is actually pitching up. And so the natural instinct is to push the stick forward. And early on, many pilots, early catapult pilots, put the airplane in the drink. And so the Navy has gone to the point that insisting that the pilots put their hands on a canopy rail during the initial launch off the carrier so that they're not going to grab the stick. And once they're free of the carrier, then they can actually begin to take over control of the aircraft. But these are very powerful illusions. And if you've never experienced them, things like the leans, et cetera, it's impressive what they can do. Somatogravic illusion is one in which the pilot doesn't realize that he's in a turn and he's dropped a wing sub-threshold to his perception in the otolith, and then corrects it super threshold, and that gives him the sensation that he's actually in a turn, and so he goes back into the turn, the opposite direction, and ends up in a spiral that tightens to the point that he collides with the ground. Now, for those of you who are trained in ATLS, this is the airplane that birthed ATLS. It was flown by an orthopedic surgeon by the name of Dr. Steiner, and he actually experienced spatial disorientation. He was flying back from a trip in California on Valentine's Day, and he it was starting to get dark, and he was trying to stay under the clouds because he was not instrument rated, and it turned out to be a sloping cloud deck, which pushed him closer and closer to the ground. And flying over southern Nebraska, there aren't a lot of landmarks or lights, and suddenly he flew between some trees, ripped his wings off, landed in a thicket, and unfortunately his wife was killed, but 3 of his kids were knocked unconscious, and the one that wasn't unconscious had a broken arm. And but it was a spatial disorientation accident that actually birthed ATLS. And there's a great ebook on this, By the Light of the Moon, Life, Death, and the Birth of ATLS. That's an interesting read if you want to learn more. So obviously the FAA's mission statement is to give us the safest national airspace in the world. And I think we do a pretty good job of that. And we have 9 FAA regions that manage medical issues. I work with the headquarters office out of Oklahoma City. And so airmen basically have 3 types of certificates that they get. Our airline pilots get a first class certificate, which if you're over 40, you have to get every 6 months. And we do EKGs on them, et cetera. Those are done by senior AMEs. Second class certificates, that's what your agricultural pilots typically get. That's the requirement for astronauts in commercial space. And our air traffic controllers also require a second class. And then a large number of pilots just want recreational or third class. And if you're under age 40, that certificate's good for 5 years. But after age 40, it's only good for 24 months. Glider pilots don't require a medical, and balloon pilots don't require medical unless they're doing commercial operations. And so that just recently passed that balloonists have to have a second class medical. So what happens if they are not qualified? Well, they submit their paperwork to us and we review it. And if they don't meet standards, but we think it's an acceptable aeromedical risk, we put them on a waiver, which is called special issuance. And typically it's good for a year. And sometimes we are comfortable enough that we can let the AME review the paperwork and send it in later. We call those AME assisted special issuances. And now we have a new category of conditions that we feel are low risk, like hypothyroidism, et cetera, that we call these CACIs, conditions that AMEs can issue, and the FAA never sees the paperwork on them. So some forms of prostate cancer, asthma, conditions that meet certain parameters, et cetera. So there's about 16, 18 of those that we allow the AMEs to review and take care of the disposition. So aviation medical examiners do these exams. We have senior AMEs that do class ones, and they are oversighted by the FAA. And if they're not performing well, then we de-designate them. If you're interested in becoming an AME and interested in flying, you can write off 50 hours of flying in any kind of aircraft, helicopters or twin engines, et cetera, and write off the cost of your instruction and your training. So if that's something you're interested in, you can send me an email and I'll point you in the right direction. The other thing that I would point out is we get a lot of pushback from clinicians sometimes for our information that we ask for. And you have to understand that there's a difference between clinical medicine and regulatory medicine. And so, for example, if an airman has a melanoma beyond 0.75 Breslow depth, we actually require them to get an MRI of the brain to make sure they don't have any metastatic disease. That's not clinically indicated, but from an aeromedical risk decision-making, we do ask for that. So same thing goes with cardiac conditions. For example, an airline pilot who's had a stent put in, they're required to actually go get another coronary cath to make sure that the stents are patent. And that's usually done 3 months after the stent is placed. And not clinically indicated, but from a risk perspective, we require that to be done. So there's another type of medical that pilots can get now, and thanks to the good senator from Oklahoma, this was signed back in 2017. It completely cuts the FAA out of the picture from a medical perspective. So now under BASICMED, you can go to your physician, and physician is defined by the state. And so a physician includes chiropractors, optometrists, podiatrists, et cetera. And any of those physicians can do this exam on you. You have to have a valid driver's license. And if you have restrictions on your driver's license, such as you need a breathalyzer interlock on your ignition system, then you need the same thing on your pilot's restriction. And so with your valid driver's license, you can go and get this exam. Your physician signs this statement. He's attesting to the fact that your medications are fine, your examination looks normal, and that you're not aware of any issues that would hinder you from flying an aircraft. Now, I don't know how many of you are trained in aviation medicine, but that might be a little bit of reach for some people. The exam's good for 4 years, and you have to do an online course every 2 years to learn a little bit about aviation medicine. And so when you complete that course, you then send in that certificate, is automatically registered with the FAA. So this program is managed through flight standards, and we don't actually see these patients. Now, they are required up front to have had at least one FAA exam. So there is a little bit of a gate there. But there's only a few limited conditions that they're required to come back to the FAA and get a waiver for. And these are the kind of airplanes that they can fly. And so basically you can take 5 passengers, you can fly IFR, up to 17,999 feet, 250 knots. And you can use it in Mexico and the Bahamas. Can't do Canada yet. So last type of medical certificate is a recreational pilot, and that does require an FAA medical. Sport pilot is another category that all you need is a driver's license, and you can fly little small airplanes, less than 10,000 feet, daytime only, max speed of 87 knots, and you're good to go. So under sport pilot, there's some amazing pilots out there. And this is an armless pilot, Jessica Cox. And she has been able to fly an aerocoup successfully, just using her feet. And you see her toes operating the throttle and the yoke. Now, the nice thing about the aerocoup is that it has no rudder pedals. So she doesn't need rudder pedals to fly the airplane. And she came and gave a talk at one of our conferences here about her experience, and amazing young lady. So we're allowing more and more people to fly with various types of conditions. So the FAA has a very challenging screening hearing test called the conversational voice test. And basically, the AME talks to the airman with the airman's back to him, a distance of 6 feet, and has the airman repeat what he says. And if he's successful in that, he's a pass. So you can be deaf in one ear and still pass the conversational voice test. You may fail if you no comprende English, but generally most airmen pass this. Now, we do have standards if they fail that conversational voice test to do pure tone audiometry, but you can see the bar is kind of high here. Many of our airmen who've been around hazardous noise tend to have hearing worse than this. So we also allow speech audiometry. Now, just a graph here showing how the consonants are actually up in the high frequencies and the vowels are spoken in lower frequencies at a much louder intensity. And you can see how patients or airmen can get behind in that they can hear the vowels, but they can't, is it an SH or TH? What is it that, and they kind of get into a lag in the conversation. You'll note here in the speech discrimination that we have a 70% bar, but it's important that it can't be higher than 65 dB. Occasionally, you'll see speech audiometry where they've cranked it up to 95 or 100 decibels. Well, that's a fail. And if they fail, then we require them to do a medical flight test. And if they pass that, we give them a SOTA, a statement of demonstrated ability. That is a permanent document that they have to keep with them to prove that they are capable of flight. We also do that for our monocular pilots who are blind in one eye. So our cochlear implant patients, as you know, they may have a range of performance ability with their cochlear implant, depending on what age they were when they were implanted. Obviously, the kids that are implanted below age 5 do very well, but occasionally we'll see some teenagers or people in their 20s and 30s that get cochlear implants that need it for conversation and communication. And I've had a couple pilots who've actually failed their medical flight tests because they were lip readers and they were, it gave them some clues, but it was not enough for them to satisfactorily communicate with air traffic control. So the flight examiner actually requires you to be able to communicate a checklist with another pilot, talk to air traffic control or dispatch, be able to recognize changes in the engine instruments, recognize a stall, being able to deal with retractable gear emergencies, recognizing that. And for our airline pilots, the fidelity of the simulators is such that we allow them to do this in the simulators. Up here in Denver, we have United Airlines has their whole bay of simulators for everything from the 737 to the 777, you name it. And I've had a chance to fly some of those, and it's very impressive. You really feel like you're actually in the aircraft doing a mission. So the statement of demonstrated ability or the medical certificate will have a statement on it that not that they require hearing aids, but they require amplification, because you can get that through noise canceling headsets. You can get that by cranking up the audio on the aircraft, and they can also fly with their hearing aids in. So we have quite a number of deaf pilots that are out there, and obviously they can't fly with radio communication as required, but they are able to fly in areas where no communication is necessary. And we have regions out west here that they can fly safely in. And with prior arrangements, they can actually fly into a tower control airport by having a appointed slot time to come in and communicating with the tower, looking for the signal light gun, giving them a green light to land or a red light to go away. So we have a number of airmen that are out there. This slide's a little bit dated. I think we've got almost 30 airmen out there with cochlear implants that are dependent on them. We've got quite a number of single-sided deafness pilots. Those pilots do not require a medical flight test, obviously, because they can hear out of their other good ear. But we've got Bajas, and I've got a picture here of Mike Glasscock. God bless his soul, since departed. But Mike was the first pilot that we cleared with bilateral implanted hearing aids. So we have quite the spectrum of amplification available. Here you see a picture of one of our commercial airline pilots with his cochlear implant in place with his headset on. And so one of the things that he shared with me is that when he was first learning how to fly, learning the language of air traffic control took him about 6 months. But he finally was able to master it. He flies with a spare cochlear implant device to just in case, but he's never had to use it. And again, for your pilot, there's quite a bit of hazardous noise around, and making sure that they're protecting their hearing and that of their passengers. Comment on medications. Again, a lot of our physicians are not aware that some of these drugs are disqualifying. For example, Benadryl, which is just about in everything. It's in sleep aids, antihistamines, you name it. If you're an air traffic controller and you take one Benadryl, you cannot control traffic for over 60 hours. 10% of our aviation, general aviation accidents that are fatal have Benadryl on board. So it's a significant issue. It impairs your ability, especially as you get older. For those of you who are familiar with the Beers list, which is a list of drugs that people over 65 shouldn't take, Benadryl is at the top of this list. It really puts older people in a brain fog. And cetirizine is a very common antihistamine that we see in airmen. It has a 48-hour no-fly. So we really encourage them to go with non-sedating antihistamines. And then you see occasional pilots who have migrainous vertigo, et cetera, that are treated with Topamax or Depakote or you name it. All of these are aeromedically unacceptable. So if they have to be on that medication, they're not going to fly. They'll be permanently grounded. We do allow some SSRIs. The process is somewhat onerous, but I know there are some neurologic conditions that occasionally we use these medications. So it does require an observation period of 6 months and neuropsychological testing, and then regular follow-up with an AME trained in this particular program. So with that introduction, let's run by some cases here that have come across my desk. So here we have a 23-year-old male who is a first-class pilot. He's got 420 hours. He has a history of multiple tympanomastoids on the left side for cholesteatoma. He's on a special issuance for that. And he's coming back into his ENT doc and he's found to have recurrence of his cholesteatoma. So he's going to need another operation. He's found to have a canal wall down procedure. He has a high facial ridge. He's got some cartilage on top of the stapes. So what would you do with him? Is he safe to fly? Safe to carry passengers? Is he need to be grounded? If so, how long? What about the risk of alternobaric vertigo? So that's where the two middle ears have pressure differentials and they're sending signals to the brainstem that are unequal. And that causes vertigo, nystagmus, which when you're flying in a descent, getting ready to land and you become vertiginous, can result in a crash. So it's not something we take lightly, and we think about these kind of things and talk to our airmen and our AMEs about this. Well, this particular guy, this is his audiogram. So he's got kind of trashed hearing on the left side, but he's hearing okay out of the right. So we withdrew his special issuance, and for reconsideration, we asked the airmen to send us a copy of the op report and copies of the CT imaging done either pre or post-op. We want to see the follow-up visits, and we want to see the audiogram. And finally, we want to see a note saying he's good to go to return to duty. And with that information, we'll review that and make a paramedical assessment. Well, this is an airman who has congenital hearing loss and had his first cochlear implant placed at age 1 on the left side. And the right side, they waited till he was age 8 for some reason. Does pretty good on testing. His AZ bio was 92% quiet, 89% noise. So he's a student pilot with dreams to be an airline pilot. So do we allow this guy to go or not? Survey says, well, he got his medical flight tests with his cochlear implants and he passed. So he was granted a statement of demonstrated ability and we gave him an eligibility letter. And that means basically we don't follow them anymore unless they have a problem of some kind. And we have a regulation called FAR 6153 that all pilots are familiar with. It says if you have a medical condition that you suddenly develop or you're taking medication that may impair your ability to be pilot in command, you should not fly. And so that is the reg that we use to spank airmen if they do something stupid medically. We have a lot of aging pilots. This is an airman who's 89, flying his little home built. And I've cleared airmen well into the 90s. My one 95-year-old pilot said, "Doc, don't worry. I always fly with a safety pilot." My buddy Ed, he's 96. So, all right. So here's an airman who at age 39, he's got a class 2, which means he's probably an ag pilot or a charter pilot, 642 hours, and had a stick puncture his left eardrum. Obviously developed vertigo, explored his ear. He's got a perforation of the drum. His stapes is totally absent. Oval window is floating with debris from the stick. And obviously he's deaf in that ear. And at the time he's there for follow-up, his vertigo has since resolved and he's compensated and he wants to go back to work. So is he safe? We need to watch him for another year. What additional testing would we require? So we got all the paperwork on this guy and he was a year out from his surgery. He had no evidence of nystagmus. And so we went ahead and put him on a special issuance and we'll follow him for a few years. And if he continues to remain stable, then we'll release him with a warning letter that basically says, let us know if anything changes, but you're good to go. So here's an airman who is an airline pilot. She's got 12,000 hours. She's 50 years old and has a history of parallel fistula, presenting with some unsteadiness, underwent a repair in 2008, had a revision of that 2009, which helped, and had some mild eustachian tube symptoms. So she had PE tubes put in, complained of some oral fullness, but the ECOG was normal. CT of her temporal bone was okay. So she's safe to fly. Would you get on an airplane that she's flying? And if not, what else would you need? How long would you wait? So this particular airman, I was in conversation with her treating physicians, and her symptoms were never disabling, but she was on no medications. For a period there, they were using beta-histine. Now, you'll see, I don't know if some of you use beta-histine, but it's not FDA approved. And so if we have airmen that are on this, that's a grounding drug. And we can debate or argue about whether it really is a safe drug or not and how effective it is. But from an FAA perspective, it's not a FDA approved medication. And so we don't allow that. We don't allow pilots to go on experimental medications. And when new drugs come out, we have a 1-year waiting period before we will allow airmen to be on those drugs. So occasionally we'll have pilots that come in and they want to be on the latest designer drugs for diabetes or whatever, and it's disqualifying. Same is true for some of the new chemotherapy drugs, the biologics, et cetera. We require an observation period, and lo and behold, many times it was wise that we waited, and because adverse reportings tend to come out after it has more ubiquitous use. So she's been followed for several years and she's had no recurrence. And so we were able to clear her. So what about Meniere's? Now in the military, if you get Meniere's disease, it's the end of your flying career. And so I know that House Ear Institute is famous for doing an endolymphatic shunt on Alan Shepard and allowing him to go to the moon and fly his spacecraft. But in the military, our airplanes are too expensive, and we don't want airmen crashing from Meniere's disease. So the Navy actually cleared one F-18 pilot against medical advice, and that F-18 pilot was flying in Southwest Asia and had a Meniere's attack while flying. That scared the crap out of him. He was able to get the airplane back down and said, yeah, I shouldn't be doing this. So to my knowledge, there are no military pilots that are flying with Meniere's disease. But in general aviation and in the commercial aviation area, we actually have found that Meniere's disease can reasonably be well controlled with use of transtympanic gentamicin and decadron, et cetera. And so we require them to demonstrate stability for at least 6 months before we consider granting them a waiver. There's an airman here who's 55, he's got 15,000 hours, he's a class 1, and treated with an endolymphatic shunt in 2002. Later had transtympanic gentamicin in 2003. That didn't work. He ended up getting a labyrintectomy, and that didn't work. He got that revised in 2007. And as you might imagine, this guy had a little bit of depression about failure to keep his disease under control. And so what do we do with this guy? Well, survey says he was actually able to get finally control over his symptoms. Situation depression resolved, and he required no medication for that. But he's a guy that we're going to follow on a special issuance annually and ask for a current status report. So what happens if they are given a special issuance and they're on medications, they're on a diuretic, no salt diet, and they have a recurrence of symptoms? Well, we require 3 months observation after the latest intervention. And if they can demonstrate stability at that point, then we'll reconsider them for special issuance and allow them to fly. So Superior canal dehiscence syndrome. So here's a 24-year-old airman with 76 hours, general aviation class 3 pilot, complained of autophonia. He could hear his eye movements, he could hear his pulse, he could hear his footsteps in his left ear. CT showed bilateral semicircular canal dehiscence syndrome. Oh, by the way, he also had a 4.1 centimeter arachnoid cyst in the right frontal lobe area. And so his local neurotologist did a procedure on him. Unfortunately, it did not go well. Made the airman profoundly deaf in that side, gave him a pneumocephalus and an encephalocele. And by the way, his symptoms didn't go away. So he went to another center of excellence on the East Coast and had a revision surgery done by Mediterranean FASA. They fixed his superior canal dehiscence syndrome and put a cochlear implant in his deaf ear. Interestingly enough, head thrust testing showed a normal VOR in all 6 canals, and they're not sure why he still demonstrated normal function despite all the trauma of surgery. So, would you fly with this airman? Is he safe to carry passengers? Survey says he had a favorable current status report, and since the cochlear implant was for single-sided deafness, did not require medical flight tests. But he's a guy that we want to keep tabs on, and so we put him on a special issuance for follow-up. All right, the joys of aviation and flying in the backcountry. So acoustic neuroma. So here's a guy, he's 45, has 132 hours. He's a class 1 pilot, airline pilot wannabe. Has a 2.6 centimeter acoustic neuroma on the right side. House-Brackman facial nerve grade 1. He's got some residual tumor after surgery, 5 by 7 millimeters at the porus. He also has what appears to be an area of pica infarction with some encephalomalacia and some gliosis there in the right cerebellum. He's got no post-op nystagmus, no ataxia. So what do we do with this guy? Well, this is one that I actually called the neurotologist on. We talked, we got some additional imaging, and it turns out that he did not have a pica infarct. And on additional high resolution imaging, there was no residual tumor. So this is a guy we can actually go ahead and clear, and because he's not going to require any further treatment, no waiver. So he got an eligibility letter. All right, well, here's another acoustic. This is a guy 75 years old, got 10,000 hours. He's general aviation pilot, class 3. Had a 1 centimeter intracanicular tumor on the right side, treated with radiosurgery. Developed profound hearing loss in the right ear. Had some facial nerve weakness post-radiation. Can't play his trumpet. He also notes crocodile tears when he masticates. Some mild disequilibrium, some nystagmus on extreme lateral gaze, and was recommended for bicross, but he said, nah, don't need it. So, would you fly with this guy? Survey says, well, is actually his facial nerve and function improved, disequilibrium went away. This is a guy that we're going to continue to follow. The radiated patients will follow him for 5 years. With annual MRIs looking for evidence of growth. There is a small risk that it can continue to grow outside the 5-year window, but for the most part, we warned them with a 6153 warning that anything significant changes, you need to get back in touch with us or do not act as pilot command. This is a picture I took from a Gulfstream 5 flying at 50,000 feet at night over Chicago. And that was looking out the right window. Out the left window, I could see St. Louis. I could see Kansas City. I could see Tulsa and Oklahoma City. And I've driven that. But at 50,000 feet, you can really see a long, long ways. So here's an airman who's got a clival tumor, 2.3 centimeters in size, diagnosed back in 2005. Involves the right petrous apex to the posterior wall of the sphenoid. They tried to do a biopsy on it, but they didn't get enough tissue for a path, and they created a CSF leak, which they had to manage. And has no other CNS system, no cranial nerve involvement, no growth over 5 years. Thought to be a chordoma. So what do you do with this guy? You let him fly. It's got lots of hours. He wants to continue to fly. Is he a risk to the national airspace? So this is a guy that we felt comfortable with, that showed stability, et cetera. So we'll continue to follow him on a special issuance with annual imaging and current status report from his neurosurgeon or neurotologist. All right, tinnitus drives you nuts. So this is a 47-year-old male who's a first-class airline pilot, 19,000 hours. Severe tinnitus, hyperacusis, hissing, non-pulsatile in both ears, reportedly after a hazardous noise exposure. Negative workup, negative MRI. His audiogram shows that he's got high-frequency sensor neurohearing loss in the left ear, 6,000 to 8,000 hertz. Speech audio is fine. But he gets insomnia, he gets depression, and later it just drives him nuts to the point that he takes a kitchen knife and stabs himself in the chest, lacerates his left internal mammary artery, gets his chest cracked for that, and obviously is being treated for his depression. Over time, his tinnitus has improved. So is this a guy that you'd be comfortable with sitting in the front seat of your passenger plane? And how long would you make him wait? What additional testing would you require, etc.? Survey says, well, he had satisfactory recovery from his CT surgery. He obviously was seeing a psychiatrist, and we have specially trained psychiatrists. They're called HIM psychiatrists. That stands for a study program that was called the Human Interventional Motivational Study Program, that was developed to see if alcoholic airline pilots could be safely returned to the cockpit. And through this program, the HIMSS program, we developed a cadre of specially trained psychiatrists who are familiar with FAA standards and regulations. And so additionally, we have psychiatrists on the staff at headquarters at FAA that review any of our psychiatric cases. So this guy was seen both by the HIM psychiatrist and the headquarters psychiatrist, who after reviewing and looking at his follow-up for well over a year, granted him a short-term special issuance of only 3 months and regular follow-up with a HIMSS trained AME and continued treatment of psychotherapy by the psychiatrist. And so he's now been on a special issuance for at least a couple of years and has done very well without any recurrence. So, but tinnitus can drive you nuts. Float planes are fun to fly, and encourage you, if you have the interest, to experience that. All right, vascular loop. Here's an airman, 69 years old, 3,000 hours, general aviation pilot. Had a vascular loop decompression for severe nausea and vomiting, vertigo, ataxia, nystagmus. Did a suboccipital decompression of the left pica from an ectatic vertebral artery. And he's now 6 months out, doing well. Survey says, safe to fly? Yes, no? So, other than a mild bilateral intention tremor, he is good to go. So this is a guy that we don't need any further follow-up. So we gave him an eligibility letter and a warn to get back with us if anything changes. So I would encourage you to explore the thrill of aviation, take flying lessons, think about becoming an AME. One of the world's best air shows is up in Wisconsin, up in Oshkosh. It's the last week of July. It's the largest air show in the world, the busiest air traffic control tower in the world, and everything that you can imagine. Warbirds, experimentals, military aircraft, commercial aircraft, etc. It is absolutely phenomenal. Wednesdays and Saturdays, they do their firework displays off the aircraft. So they actually launch fireworks from the airplanes at night, and it's amazing to see.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.